interesting one. So I would suggest that you guys attend because it's not just the ECG, we're going through management as well. So I'm just going to, sorry, I just have to bring up the tool that I want to. All right, there we go. That should be fine. Okay, let's go. All right. So we're going to just have a look at our M&Ms. I'm not sure how this is going to look on your side, but I'll try and make it as easy as possible. It's the first time I'm doing this as well, sorry. So I'm learning something at the moment, how to share a screen on Zoom. The truth is that I just want to compare the numbers at first, and then after I compare the numbers, then I just want to go through the case, which will just be a single one, so it's not to worry. So the thing I was worried about, I just wanted to show in December, we had, unfortunately, I don't have a laser pointer on here. Just want to see if I can pick one up from here. It's not allowing me, unfortunately. Just see. If we go into a slideshow. No, it's not allowing me. All right, so in any case, I'll use the laser pointer just now. I just wanted to show you that in January of this year, we saw 2,487 patients as compared to 2,700 in December. So it was quite a bad December for those of you who were here. And we had 22 blue codes in January, much more than in December, which is something that was kind of expected with the COVID wave. It's not something that you get that often, but when it happens, it can be quite terrifying to see that amount of patients coming in. Surgical patients, just so that you can see the effects. So in December of 2020, 629. Come to January of 21, that drops all the way down to 263 with the ban on alcohol. So you can see what a difference it makes, you know. And in fact, if you go through the lockdown months, which were April, May, June, July, and then you can see from August when it started relaxing and how it just picked up, and again how it went down. So it's there's no doubt, you know, alcohol plays a huge part in what we go through. And unfortunately, it's not going to get any better. It's part of what we have to get used to, you know. So the burns also for January, we had 34. I just want to come across here. So comparable to November and December. I just want to compare it to last year, January, which we'll see on this one. So that last year, January had 31. So it's more or less comparable to what we've seen from year to year. So that shouldn't be a problem. And then we'll just come to the deaths. So January of 2020, we had 12, right? Which was more or less in line with what we should have. We come to December and we see 23, because remember the COVID wave didn't hit us until about the end of the first week of December. And then we come across to January and we see 32 and look, 29 medical. And the majority of that medical from what I saw was COVID or sequelae of COVID. The surgical ones that we had were more head injuries and things like that. So it was a bit of a mixed bag and a strange month as well, you know, compared to the previous year. There you can see our mortality percentage, the mortality percentage for January. And this is the part that I just wanted to show you. So if you look at our mortality percentage in January, this year was 1.2%. And it's the first time in a long time. You can see last year we were only at 0.4, 0.4, 0.5, 0.5, 0.5. And then as we started getting into the COVID wave, 0.6, 1.7, because we didn't have many patients during that big lockdown. And we had quite a few deaths, even though the deaths are the same. So it just shows you, you know, it's actually quite strange, you know, that at the peak of the first wave and at the peak of the second, we have such a comparable number of deaths, you know. So 1.7%, that's the highest it's been in the last 5 years, but all across the world. I mean, it's not just us. And then as we start coming out of the first wave, we see it drop, start getting into the second wave again. By the end of December, we back up to 0.9, which is quite high, 23 deaths, and then come into January of this year, and it's 1.2%, 32 deaths. And I can tell you February will drop down again, because that's more or less what we expect to see. Just want to close that one. I think I should be sharing that screen. I just want to put this on a slideshow now, just so that you guys can see. All right, so that's just covering the numbers. The numbers are not that important. I mean, it is important for us to keep a track so that we know trends, and we know if we're doing well or we're doing badly. But this year actually wasn't that bad, surprisingly. I mean, when I say this year, I mean in terms of the totals, and just bad in terms of the mortality rate. That's the thing. All right, so let's go to our case study now. The reason why I picked this and not a COVID case study was simply I think we all COVIDed out at the moment. A lot of us have just been dealing with COVID all the time. And when we're getting non-COVID cases, sometimes our brains are switching off and we're not really sure of what to do. So I just wanted to go through a patient, one of those deaths that did come in, and just to, just so that we can see what's going on, So we had a 67-year-old female patient, 3-day history of lethargy and decreased level of consciousness following heavy diarrhea over the last 4 days. Now, the thing is, one thing I'll tell you guys, elderly patients with diarrhea, there's 2 things that you need to worry about. Number one, electrolyte abnormalities. Number one, you always worry about that in this subset of patients. And the other thing is lactic acidosis. So, severe metabolic acidosis, but generally due to lactic acidosis. So just be careful of those 2 things. No matter how bad an AGE is, unless you've got severe dehydration, you shouldn't have a change in mentation. So it's very strange when a patient comes with, decreased level of consciousness following diarrhea. And any diarrhea that persists more than 3 days should be worrying. The patient was also noted to be diabetic and RVD positive with a recent admission for acute gastroenteritis. Once we see this diabetic, the other thing that we need to worry about also is HHS. HHS sometimes can present with diarrhea. There's no doubt about it. Heavy diarrhea as well. It actually has to do more with the electrolyte imbalances, and it affects the ability of peristalsis. When I say that, you get sort of like a hyperperistalsis in these patients. So with an inability to, compensate for third space losses and things like that. So there's quite a few things that happen with pathophysiologically, and these patients can have heavy diarrhea. So just always look out for that as well. Right? The recent admission for acute gastroenteritis is also worrying, because why did this patient have it? Is she poorly controlled RVD? What's going on? So we did a VBG, showed a potassium of 1.8. So anytime you see a potassium of 2.4, get worried. All right, less than 2.4 is always worrying. Once it goes less than 2.2, now you're dealing with severe hypokalemia. All right. The problem with severe hypokalemia is the arrhythmias. So bradyarrhythmia is more common. What happens with hyperkalemia is initially you get a tachyarrhythmia and eventually it becomes a brady. With hypos, they tend to go more into a brady much more easily, all right? So the bad part with this patient, she was admitted to the ward directly without further consultation with regional medicine, all right? So it was a bit of a bad miss on our side, unfortunately, that the patient went straight down to that, so the transfer to luckily, in consultation, directed without consultation with regional medicine, the patient ended up in the family med ward, if I can put it that way. When I say family medicine, I mean 1B, but they've got a separate section for all the AGEs and things like that. So transferred to ICU the following day by family medicine, following resuscitation by the doctor in the ward. Luckily, the admission happened at 7:45 in the morning. So the error was found quite early, luckily. All right. So the doctors had just come onto their shift. They had just seen the admission and they knew something was going on. All right. So the patient required high dose of potassium supplementation. So the question is, how much do you give? How often do you give? And that's one of the things that you need to know. So once your patient is over 2.4, a potassium level of 2.4, oral supplementation is often sufficient. Okay. But once you start going under 2.4, then your patient needs IV potassium supplementation. So the most common one we use is KCl, calcium chloride, potassium chloride and calcium chloride, potassium chloride. Now the question is, how much do you give? And it also depends on the symptomology of the patient. So if you have a patient that's going to be actively losing fluid, as compared to somebody who's maybe been taking potassium losing diuretic, which you can stop, that will judge on what you can go. Sepsis also plays a huge part in it. Other pathologies such as, GIT abnormalities, GIT tumors, these can all affect you as well. So that's what you've got to take into consideration to determine how aggressive you need to be. So when I say aggressive, actually KCL is not given in boluses. Please remember that, all right? A KCL bolus, its other name is a lethal injection. Okay, remember that. So any KCL bolus will kill your patient. Try and keep away from KCL boluses. Do not ever bolus KCL. Just remember that. KCL needs to be given in a slow and controlled way. So let's say you have a patient with a mild hypokalemia, 2.1, secondary to the use of potassium, losing diuretics, for example. Just as an example, patient is stable, doesn't have a bradyarrhythmia, but has the potential to get worse. You would give it via a peripheral line. Each ampule of KCL comes as a 20 millimole package. So you are going to run that at 10 millimoles per hour. In other words, half an amp per hour as a peripheral line. Okay. So in doing that, you're also going to judge how much time you're going to need before you need to repeat the potassiums. Remember, you can't just say potassium replacement and send the patient away. So let's say take that patient, 2.1, relatively stable, but definitely needs potassium supplementation. You would now, over 2 hours, you could put it in 200 mils, 1 liter. You need to look at the patient's hydration status, so on and so forth. And then what you would do is put half an amp per hour. So you'd add 2 amps and run it at 100 mils an hour, 500 mils per hour, whatever you needed to, just so that the 2 amps would go in. All right. Now, let's say, for instance, your patient comes in. Your patient has, for example, let's say like this lady, 1.8, 1.7, 1.6 and lower. She has an active loss of potassium. So she's losing potassium via her GIT. Aspirin overdoses as well, very commonly, that they also have potassiums that continue to drop. So you just need to know where that's going to go. So in other words, if we just replace the potassium, she's going to lose it. So we need to aggressively replace the potassium. When we say aggressive now, that means we need central line placement, so CVP. The reason being, via CVP, you can now run it at 1 amp per hour as compared to half an amp, okay? But the question is how much? So what I would say is that once your patient is less than 1.2, let's say less than 2, sorry, that's what I was trying to say. I would go up to 3 amps. So that means you're giving 1, 2, 3 amps per hour. 3 amps over 3 hours. And you're monitoring on an hourly basis because you want to see how much you are getting it in. And the thing is that if you are now starting to suddenly get a rise, you can stop it as well. So it has to be an hourly check on that potassium. These are patients that require active resus. That means that you can't just leave them on their own. You need continuous ABGs. And the good part is once you have a CVP, you can take your ABGs directly off that because remember, you're just looking for the potassium concentration. Okay. You need to watch out also while you are replacing potassium that you're not giving anything that's going to drop potassium. So for example, insulin. Let's say this patient had a high HTT. If you give insulin, you're dropping the potassium as well. Patient has asthma and you are busy giving salbutamol nebs, you are dropping the potassium. Patient is acidotic, so you are giving sodium bicarbonate, you are dropping the potassium. So you have to take all of that into account while replacing your potassium as well. So there's no easy answer. There's just guidelines. But I would say less than 2, you're looking at giving at least 3 amps of KCL over 3 hours via CVP with hourly checks on their potassium, even half hourly if you have the opportunity, but hourly should be fine. As you start coming out a little bit higher, then you can start looking at, decreasing maybe 2 amps via CVP, going back towards peripherals, things like that. You're aiming for about 3.4 and above to say that your patient is safe. Now, in saying that, I just want to come to this one here. So patients require active cardiac monitoring. The reason being they go into bradyarrhythmias and they fibrillate very quickly. The way that your action potential works is a simple exchange, as you know, between the cations and the anions. So your cations are your sodiums, your chlorides, things like that. And then you've got your anions, your potassium, and what is it again? Sorry, it's been a long day. Let's just take potassium for now. So it's a simple exchange between those positive and negative ions, all right, as they are going across. Now, the problem is that if you don't have sufficient anion to cross with the cation, then it becomes a less responsive cell membrane. So once you have a less responsive cell membrane, that's when you start getting into these bradycardias and fibrillations. As compared to a hyperkalemia, we have a large amount of potassium, a large amount that's available for this. We have a hyperexcitable myocardium that can very easily fibrillate because now it's being overstimulated as compared to something that's being understimulated. So remember that. Okay, so you're giving that potassium. One of the other things that needs to be taken into account is magnesium. So magnesium also, one of the anions, also very commonly goes down along with potassium. Now this has to do with potassium storage within the body. It's quite a long and complicated pathology, which is code word for, I can't remember it right now. And I've got to look it up myself. But essentially, when your body stores potassium, it stores magnesium at the same time. In order to remove potassium from potassium stores, you often need magnesium to accompany it to be able to get out. Now, this is also in the renal system as well as within the tissue. So magnesium is something that is often overlooked. And when magnesium is overlooked, it can lead to this refractory hypokalemia. So you are giving your patient all of this potassium, but for some reason, the potassiums are not increasing. Now you need to look, number one, am I giving a drug that's still dropping potassiums? Is the patient actively losing potassium? Or is the, what you call it, what could be the other reason? So the other reason is magnesium. So what you need to do is give magnesium sulfate to these patients as well. Now, the easiest one to do is also depending on how low the patient is and how much the patient needs. That's how much of potassium you'll give. But potassium, luckily, you can be a bit more conservative with it. What we normally do in the emergency department, these patients with severe hypokalemia, 1.8s, 1.2s, 1.4s, we take between 2 to 4 grams of what you call it, magnesium sulfate. We mix it separately. You don't give them together. You need to know which are running at which point. So you have a little 200 ml bag with your cassia. You have another little 200 ml bag with your magnesium sulfate, and you give it over about 20 to 30 minutes. Now, the more you give, the slower you should give it. So I would say 2 grams over 30 minutes is acceptable. If you are giving 4 grams, which is quite a high dose, you should give it over an hour at least. But this depends on the patient condition as well. And what you often find is that the potassium starts to pick up as well. So just remember, if potassium is low, give magnesium. If potassium is mildly low, don't rush to give the magnesium. I'm talking about patients who are stable, walking, everything is fine. You know, they've just got mild hypokalemia. That doesn't mean you must start them on a magnesium supplement as well. Those types of patients in an outpatient setting, for those of you who work in MOPD, after repeated potassiums, and you notice that no matter how much of what you call it, potassium supplementation, slow K that you're giving, they're just not going up. They sometimes respond to the addition of a magnesium supplement as well. So that's just something to remember. All right. Now, the history and presentation is a relatively common one for us in our area for 2 reasons. Number one, lethargy is very common. Decreased level of consciousness also, but we find most of our patients being malaise, having malaise and lethargy and things like, and this in this particular age group, the slightly elderly age group, and they tend to have gastric problems, whether it be vomiting, diarrhea, or something along those lines. So this is a very common presentation in our area, and we know that our patients prefer traditional medication before they come to us. So that also aggravates the entire situation. So what you do in these cases is when you get one of these patients, do a blood gas. It's not going to hurt you. You are taking an FBC, you are doing a UNE. Just have a look at that potassium, that chloride, that calcium. Calcium. You see, that's the other one I was looking for, the other anion, calcium. And you need to look at their sodiums. All right. Number one, you're trying to rule out hyperosmolarity. You're trying to rule out one of the hypos or the hypers, depending on what the initial presentation is. So that VBG can tell you a lot. And I'm hoping once we get towards the end of ultrasounds, which should be in another 2 or 3 months, then I'm going to do a series just on the ABG so that you guys can get much more familiar with the ABG and how we actually look at everything. Right? Now, in this particular patient, she was also noted to have severe sepsis secondary to cystitis. Now, this is even more worrying. You have a patient with low potassiums, potentially low magnesiums, Definitely, low calciums in that case because the two go hand in hand. And now she's got sepsis as well on top of it. So, I mean, that sepsis is setting off the whole inflammatory infective cascade. It's setting off cytokines and inflammatory, modulators and things like that. So what's happening is that these are all going into that kidney, they're all going into that tissue, and they are leading to those reactions that, again, cause crossing of anions and cations and further deplete your stores even more quickly, which is why sepsis is such a worry, why septic shock is such a worry, because septic shock leads to all of these things. So be careful, and eventually was found to be HHS, all right, after that. In fact, her sodiums ended up being close to the 150s, which is another reason why she had a low level of consciousness. So if you want to know how to, work out HHS, whether a patient is in HHS, I'm just going to look up the formula quickly. So I don't know it off the top of my head. I also want to just check it out. It's a hyperosmolar, sorry, while I'm a bit quiet, hyperosmolar hyperglycemic state, all right. Sorry if I'm a bit quiet, I'm a slow typer. There's just something that came to my mind right now. So hyperosmolar hyperglycemic state. I just want to see if they've got the calculator. Yes, there we go. Oh, site can't be reached. Let me just see if I can see it here. Okay, suddenly I've got no internet connection. I think that may explain what's going on. Okay, hyperglycemic. Let me just look at it, and then I'm going to just pause this for a second and come back. Sorry, don't want to waste everybody's time. Oh, God. Sorry about this, guys. I'm also trying to learn how to do all of these things. And yeah, come on. You're doing it for me now. Oh, it's because I've got this pointer on. That explains a lot. Sorry. Please do not laugh at me. It is just refusing to stop. Okay. Doesn't want me to stop recording. There we go. Pause recording. Okay, so I'll be back with you all in a second. Okay, so I think I'm back there. Yeah, so it's basically 2 times sodium plus your glucose and your glucose in the urea. And you've got to also add in 2 times your sodium and things like that. But there's a difference between osmolality and tonicity. So that's quite a thing. So, and in fact, in her case with the sepsis, the tonicity and the osmolality would have been affected. So these are nice things just to go and read about if you have a second. Sorry, next time I'll know, I'll just stop the share a bit fast. So yeah, as I was saying, we coming more or less to the end. So learning points, any potassium less than 2.4 warrants discussion with regional department. And it's true. In fact, less than 2.2 should be admitted to ICU. AGE, concomitant renal disease in the elderly, is a recipe for disaster with potassium because they quite simply can't return their potassium to the system. Know your rates of infusions, which, like I say, peripheral lines, 10 millimoles per hour or half an amp per hour. CVP, 20 millimoles per hour. All right. And the other thing now that we're going to get into, which is the last part, is that your ECG can be subtle, but we should know the basic morphology of hypokalemia. Hers was a good case of seeing U waves. So I'm going to show you these U waves because these are quite important. So we're going to look at prominent U waves on an ECG. So as you can see, it's not pathognomic of hypokalemia, but it's one of the more common differentials with it, right? And once you get U waves, it's quite significant or it signifies significant hypokalemia. So what is a Q wave? Quite simply, PQRSTU. In other words, you have a T wave. After your T wave, you have a U wave. And this then goes followed by an atrial contraction. So what does that mean? Atrium contracts, ventricle relaxes, and then it has this partial relaxation again. So what's the pathophys behind that? How do we understand it? So you remember what I said, you don't have enough potassium available to actually go across to actually get your heart back to a standing steady state. So what actually happens is that once your patient has a normal ventricular contraction and relaxation, but this is maybe a bit misleading because the majority of the time the QRS complexes actually tend to be a lot wider than this, for the simple reason that it takes a lot more time for that action potential to spread across the cell membrane and eventually lead to a viable contraction. So this is a bit misleading, but even your T wave, you'll notice, is a bit more what you call it, rounded, not as peaked as what you would see in hypokalemia, where it's very peaked and very excitable. The one other thing that can lead you to know that it could be hypokalemia is a prolonged QT interval. So in other words, the time that we normally see our QRS complex to our T becomes quite elongated. Now, in that case, hypocalcemia, hypomagnesemia, hypochloremia, all of these can, or ischemia can also lead to that. So but it's just one of the clues. So you tend to get a P segment, a wider, flatter QRS complex, then you get a T. So what happens is you get a refractory relaxation again, or repolarization, as the remaining small bits of potassium that were unable to be used to create an effective repolarization here are then used to create a repolarization towards the end. Okay, so my apologies for boring you guys with this long lecture, but I'll post it and watch it at your leisure because hypokalemia is quite common. AG is quite common, sepsis is quite common. So these are the things that we need to learn. And I hope you'll benefit from it. And if you'll have benefited from it, please let me know. In the comments, don't forget to like, share, and subscribe. No, I'm just joking. But yeah, I hope you guys learned something from that, and I hope from now on to actually post our lectures, even the ones that we do. I've managed to buy enough cloud space, so on Thursday we'll do our ECG topic. We'll do it from there. Okay, it's not related to hypokalemia, but it'll be a good one for you guys to see. So I will do that on Thursday. On Wednesday, we are doing lung ultrasound. We're going to have a look at how you determine a pneumothorax. So I'll see you guys then. Okay, thanks everybody. Bye.